Well, we're going to start with my talk actually first. I wonder if we can load up my talk. And I'm going to basically talk about specifically MicroPulse for glaucoma. We'll go through some of my observations so far. And by the way, these are some of our relevant disclosures. We all here have worked with Iridex in varying capacities, and that's important to do it. I guess I got my own clicker here now, don't I? So I basically entitled the talk here MLT for short. I love acronyms. MLT as a safe opportunity or an approach to laser trabeculoplasty therapy. So, we know, lasers in ophthalmology, of course, have been around for many, many years and have been a mainstay of treatment for so many different conditions. And depending, of course, what we're treating, we've seen, a lot of safety, and we've seen some areas where we need to improve upon. Remember, when it comes to laser therapy itself, we see a variety of different mechanisms. We see mechanical effects of tissue. We see thermal effects that result in inflammation and cytokine activation, which can create a beneficial or negative effect. And we see biological effects on cellular turnover that can also, again, help in aiding the disease process. For example, trabecular meshwork cells. But the challenge with our laser therapy is harnessing the thermal effects of the laser energy by avoiding some of the deleterious downside of necrosis of cells and loss of tissue. And this is where MicroPulse, I think, a really very innovative approach, and again, I think we've got to give credit more from the retina community first for really working in this area, allowing us to chop that laser energy into small, literally microsecond impulses here to reduce the exposure of that energy causing excessive heat, being within the thermal relaxation time of tissue to reduce the collateral damage that occurs with tissue is a concept here that we're introducing here. So it's a finely tuned machine. Anybody who does FAAOCO here, who understands hyperpulse, understands the benefit of heat reduction during phacoemulsification, which is basically almost gone away now as far as hyperpulsing FAAOCO. So this allows us to do this. We can find the effects of the tissue we need to go at, and we can basically vary our parameters whatever we like, whatever our pulse period is, our duty cycle we can alter, and our power levels. And it gives us ultimate control on this. And I'm excited because in glaucoma, we're really just getting started with this. And I think we're going to see more work. Now, in the retina world, of course, they've been a bit more experienced in this, and I think Elias will be talking a little about this. And here's just an example to show a conventional laser causing a burn, necrosis of tissue, with surrounding impact to tissue. While in MicroPulse, the idea essentially is that we're essentially using the direct laser energy, avoiding some of the thermal damage that may occur to tissue, while still harnessing the power of some of the biological effects of the laser. So that basically is what MicroPulse is about, what the theory behind it is. I think, of course, we're going to need to have more data to support what its safety is, and we hope to share a little bit of that with you here today. So as far as technology is concerned, again, those of you who do FAAOCO kind of understand a little bit about pulse duration, on and off time. Remember, on is the time when the laser is actually on, off is off. The period of the envelope is the duration of the entire pulse itself. And then the duty cycle is how much percent of that period consists of laser. So these settings here are basically what we currently are using for trabeculoplasty, which you can preset in the machine. So you can see that the total period of treatment is 2 milliseconds. 2 milliseconds, okay? And then of that, you can see 0.3 is on and 1.7 is off. That equals 15%. So 50% is the duty cycle of what we're treating. So a very tiny portion of that pulse period is on at any given time, allowing for cooling of tissue for 85% of that pulse. All right? Again, think back to our FAAOCO energy as well. So when it comes to trabeculoplasty, of course, where does it fit in our treatment paradigm? We've seen trabeculoplasty move toward earlier treatments. We're not leaving patients, to pre-surgical periods where we have to, go to trabeculectomy. We're typically using this second line, sometimes first line, third line. I look at it as a medication alternative. And those of you who maybe had a chance who stayed away from my bin course lecture, probably heard me talk about interventional glaucoma, right? Talk about how, IOP is a surgical disease. And we've gone sort of through the renaissance of the medical era into the renaissance of the interventional era. And I truly believe that using laser trabeculoplasty, drug delivery, and microinvasive glaucoma surgery are ways that we're going to be able to obviate some of the concerns we have with topical glaucoma therapy. And that's just an example showing the trabecular meshwork. Now, we have, of course, had a lot of experience with ALT and SLT. We know, of course, with ALT, first application of laser energy into the angle does, of course, cause structural issues and heat damage within the meshwork itself. and is purported to act by potentially mechanical and also chemical means, and cytokine means as well. Because of if you look at the histopath, which I don't have up here, on ALT, you'll see cratering, you'll see herniation of inner wall against the outer wall, you'll see basically a lot of damage that occurs in the meshwork. And unfortunately, that limits its repeatability, and in my opinion, even worse, it limits the ability to perform future MIG surgery, which I think if you were looking to the future, we want to retain the structural anatomy of the meshwork and the canal. It'll be vital for future therapies. This is where SLT, with a short duration pulse, selectively lasering the melanin in the meshwork cells and activating a cascade of cytokine macrophage activation, which gobble up some of that extracellular matrix, is purported to work and benefit in a safer manner. Some of the data appears to show that it seems to be repeatable. And as you know, the difference with the treatment here, 400 spot size versus a 50 spot size, a little bit easier in terms of actually focusing on the meshwork, but the spot size is somewhat large as well. So MLT, has a similar wavelength. 532 is SLT. There are some who are using micropulsing and other laser energies as well. The idea here, again, we're targeting specific cells. We're trying to minimize that thermal damage by micropulsing it. The purported mechanisms, again, are also inflammatory in nature, subtle cytokine release, macrophage activation, as we mentioned earlier. The spot size is a little bit smaller, so you can get into spaces a bit easier with a 300 micron spot size. And one of the hallmarks with this procedure, and now we've had experience where we've actually used MLT in one eye and SLT in the other eye, is the almost lack of inflammation or cellular response as far as in the cells in the AC. Now, I'm definitely not here to poo-poo SLT, because we've been using SLT for a long time, and we did some of the early work with SLT, and certainly we've seen the safety of SLT. But we've seen, of course, a bit more inflammation. We've seen some pigmentary response and IOP spikes that can occur. And with MicroPulse, we'll see whether this is going to be a safer alternative, and certainly from a theoretical perspective, it appears to be that way. We don't typically need post-operative therapy with these procedures here. And one of the benefits, which we'll hear about as well, is a platform that can be used for multiple purposes as well. So these EM studies here kind of just show you here what the meshwork looks like with ALT conventional continuous wave treatment versus MLT versus control, right? Pictures tell 1,000 words, and you can see here that the control versus MLT treated eye is virtually no difference. I think that I'd love to see that from a structural perspective, but yet we still get a biological chemical response. And this video here, we can play the video, just shows you the procedure itself. The spot size is 300 microns, and actually this is my fellow performing the procedure here. Essentially contiguous laser spots applied. We typically go over 360 degrees at one treatment. We've had the device here for a year, and I'll talk to David because he's had some more experience about it. But our experience has been, and we'll show some of our results, has been very good, and we'll show that in the next few slides. But that kind of just shows you what the actual treatment looks like. So this is from David Gossage. He has, like I said, done some great early work, sort of looking at different laser energy levels, 300, 700, and 1,000. And I think what he's showing here is basically that there seems to be a bit of a dose response here in terms of looking at laser energy levels correlating to percent IOP reduction. So thanks to David here, most of us have essentially moved toward the 1,000 milliwatts with a 15% duty cycle, as I showed earlier, with that 2-second pulse of energy. Now, we tabulated some of our results. This is myself, Dave Gossage, Nate Radcliffe, and Stephen Bold. We've got about 40 eyes in this cohort. Prospective here, and again, this is all comers in terms of patients with a variety of medications. Keep note, on the bottom left, the average medications in this patient was 3. That's a lot of medications, so, and we know, of course, the more meds we have on board, the results aren't necessarily as good as if you use it in primary therapy. Despite that, we had, these are patients who were more than 21 or greater. 1-year results here, you can see we went from 24.4 down to 18.5. Now keep in mind, we had 40 at baseline. We have the majority of patients still within 6 months. You can see that at 3-4 months we're about 28% reduction. So this is quite comparable what we've seen with other trabeculoplasties. Perhaps we're going to continue to see the results as we follow through with it, but certainly seems to be quite effective at dropping the pressure down 25% in this cohort. When we look at slightly lower pressure baselines here, we see that the pressure reduction still is about 20%. Again, this is about 66 patients followed out, with some of them getting out to a year, but the majority are within the 3-4 month point. So we're very encouraged with our early results. As I said, this is early in our treatment. The one thing that the slide doesn't show is the safety. We've had 0 adverse events so far, and again, this is so far, so I want to caution any long-term or wide-ranging conclusions here. Has been excellent here, and again, David may comment as well during our Q&A as far as his feelings. So these are the MLT settings that we typically use, and again, some have used 577, most of us are using the 532. 1,000 milliwatts, 300 spot size, 300 millisecond duration, 15% duty cycle as we showed here. We basically place confluent burns, if you want to call it, only calling it burns, but applications, 360 degrees, and again, really no need for really any pre and post-op medications in our experience at this point in time. Question again is, what is the role for MLT? I think that I look at this as a role that we see in patients who we look at laser trabeculoplasty. Compliance issues, those that have lost effect with medications, inadequate response. We've had patients that we're doing now with previous ALT and with previous SLT. We have a cohort of patients that have had previous SLT now to see whether we get a response from MLT. We'll be looking at this further and further, and certainly there are a number of patients that we discuss and offer with regards to primary therapy. I think that the benefits of getting away from medications are well known. We've covered that already. I think that the compliance issues are important, and I think one of the big things in a lot of our practice is the ability to perform more than simply just trabeculoplasty. We use this laser for iridoplasty, for plateau iris, pupilloplasty, for changing the pupil size if necessary, for multifocal or for a traumatic case. We use it for laser suture lysis and a variety of different applications. We do use it, and of course our retina guys use it from a retinal application for a wide range of retinal conditions. So I'm going to just take a little bit of a pause here for Q&A before I get David up here to continue the discussion. One of the nice things that David brings to the group is that, Elias is on one end, on the retina side, I'm on the glaucoma side, and David kind of fills in a nice sort of comprehensive side, which many of you, I think, fall into, having a practice that has a combination of some retina, some glaucoma, some comprehensive stuff. And I'm sure like you, like us, you also get a few little loony patients in there as well in your cohort. Okay, so let's maybe ask some questions. I don't know, David, if you have any comments. Maybe, David, you've had the longest experience. Anything to add to your experience with MLT, complications, your history with using it? Anything to add from what we said?
When I first started using the MLT, we started off with lower powers, 300 milliwatts, and then we found increasing the power to 700, we got a better effect. And then eventually 1,000 is where we settled out. Going any higher than that, I'm not sure if that's beneficial or not. Looking at the electron microscope slides that you showed and demonstrated, we know it at 1,000 milliwatts of power that we're not seeing any damage to the trabecular meshwork. The problem is doing cadaver slides these days are a little bit harder, and so higher than 1,000 milliwatts I probably would avoid at this point. I've seen no postoperative inflammation at all. At first, I used to treat people or pre-treat them with a drop of brimonidine and also a drop of Predforte. Nowadays, I don't use any preoperative drops except for an anesthetic drop to put the lens on. Iridex has also developed a lens for those people who are just starting off using this laser. It's a little bit more difficult because you don't see a reaction within the trabecular meshwork. So it's sometimes a little bit difficult to know where you've treated. And so with, I think it's Oculus and Iridex together, they've combined and created a lens that allows you to be able to flip a mirror around for 360 degrees and basically apply, say, 10 spots per clock hour. And so you get about 120 continuous spots throughout the trabecular meshwork. So the main thing I have to say is give it faith. It's even though you're not seeing a tissue reaction, you just have to make the assumption that it's working. You'll see a greater effect, I think, at 3 to 4 months than you will at 1 month. So I wouldn't opt to retreat right away. I'd watch these patients. But the effects at 1,000 milliwatts seems to be so far longer lasting. We've been doing MLT for 2.5 years now. My earlier patients that were with a lesser power, so some of those patients had been retreated using the 1,000 milliwatts instead of the 300 or 700. And I still got a nice effect. I know one patient with pressures of like 27 initially, treated with the 700 milliwatts, brought it down to 22, and then I hit the patient again with 1,000 milliwatts later and brought the pressure down to 18. So you can still see added effects. The other interesting thing too is when we looked at the 700 milliwatt data, we also looked at patients that had previous ALTP. And the funny thing is that actually the patients who had previous ALT responded actually slightly better to MLT than those patients that did not. But was it statistically significant? It's hard to say. It was about a 1% difference between those groups.
Right. That's a good point. That, I mean, you're not going to see an endpoint when you laser. You're not going to see blanching. You're not going to see, as you saw in the video there, champagne bubbles. So that's sometimes a bit unnerving. Are you actually doing anything? Have a bit of faith, as we have, and I think you'll see the IOP results. So that's kind of a neat thing. Now, there's a question as far as how many spots you typically end up with when you go 360. Do you have a certain number you target for? Or?
You know, I see anywhere between, say, 95 and maybe 110, roughly.
Same.
And so if you're using the mirror, you may get 120 spots or so.
What about, and this is a question that came from the audience, heavily pigmented eyes? You know, of course, with SLT, we will crank down that energy because of reports that we've seen with significant IOP spikes when you work at, 0.8 millijoules. We crank it down. Any pearls for MLT in a heavily pigmented eye? And I'll have my comment after you.
Sure. I've not seen any reaction at all in the eye, whether the eye was a Caucasian with a blue iris or a very heavily dark pigmented eye. So from my standpoint, I still don't alter my treatment. I'm staying with the 1,000 milliwatts of power, 300 millisecond.
Yeah, and I'll echo that. I was very worried because we've had some spikes, and some of our colleagues in Canada have reported IOP spikes post SLT. And surprisingly, again, using these settings, even with a pigment dispersion eye, we're actually quite happy with it. I'm cautious though, and if I see a reaction, I'm going to be worried. But so far it's been good. So I would put an asterisk on that. I would say that for pigmentary eyes, we want to be a bit cautious. If you're not sure, turn the energy down. But so far, at least seems to have been pretty successful. And I think one of the reasons again is how little. Think about how little energy we're giving at any given pulse. It's a very small pulse of energy being delivered. Great. Is there any other questions from the audience? Do we have any? I see Larry's putting his hand up. So perfect. We've got a couple of cards up there. One of the questions that has come up as well is, in terms of primary therapy. Is this something that you bring up during discussion with patients at diagnosis of glaucoma? Do you suggest it? Do you not bring it up? How do you handle patients for primary therapy?
I will use it as a primary therapy for glaucoma. I actually leave it up to the patient to make the decision. I'll explain to them the difference between using medications and or laser. From my standpoint, I really like the fact that from a compliance issue, you know that if you treated them and you get a nice response with the MLT, that patient's going to be well treated and keeping their pressure down. As we know from the glaucoma laser treatment trials and also the ocular hypertension trials, that lowering the pressure is the key in saving vision. And so if I know that compliance is not going to be an issue, that's a big thing for me. The other thing, too, is cost. The cost of medications is obviously expensive. Being on multiple medications, you always have the issues of corneal toxicity and other issues that come into play and systemic side effects. So from my standpoint, with patients who are already on multiple medications to begin with and having to also put another medication in their eye to treat their glaucoma, to them it's a lot easier just to have a laser and say, okay, I'm done.
Okay, well, we had a couple more questions, but they're useless questions, so we'll check them out. I'm kidding. I got a few seconds just to answer these questions. Is there definitive data to support MLT is more effective than ALT for primary treatment for IOP reduction? We don't have any data to support this. We don't have any randomized studies comparing the effectiveness. I can tell you anecdotally, I certainly believe it is. And the response rates, we'll have to see, of course, in terms of looking at some of that data. Do you see, any difference between green versus yellow? And I can tell you that most of us have been using 532, but some of our colleagues now are using yellow and 577, and we'll see what the differences are. I don't know yet. It'll be interesting to see, but I can tell you already we're seeing some response. We're seeing response as well with yellow. So with that, I want to hand it over to David. David's going to talk about how he's incorporated MicroPulse in his comprehensive practice. And thank you again for being here, David.
Well, good afternoon. Welcome. So I want to talk a little bit about how I incorporated the MicroPulse into my practice. Being a comprehensive ophthalmologist, I was looking for a laser. Actually, I was looking for an SLT laser. And at that time, I got my contract signed for the SLT, but my argon laser was also dying. So I went over to the Iridex booth to get a solid-state laser to complement my SLT laser. And at that time, I started to hear about MicroPulse technology, and it was just at that time when the 532 was having the MicroPulse turned on for that. And so I listened to the rep a little bit. We talked a little bit more. Next thing you know, I ripped up my contract for the SLT and went on to getting the MicroPulse laser. So when I looked at the MicroPulse laser for my practice, the first and foremost thing you want to worry about is patient safety. You want to make sure that you have a way of treating these patients that's going to be in a safe manner. And what I liked about MicroPulse is that we were able to treat these patients and not cause any tissue damage. And we were able to get the effect we were looking for. And later on, we were able to also use it for the treatment of the retina. With a 5% duty cycle, we find that it's very foveal friendly, meaning that you can treat juxtafoveally, you can actually treat subfoveally, and get the desired effect that you're looking for. From an efficacy standpoint, it's been demonstrated through multiple clinical trials and also through my own practical experience of using the laser for over 2.5 years that the laser works, and it's very beneficial to my practice. From an efficiency standpoint, I'm able to bring the patient back into the laser room, be able to treat them. With the tech cell, it makes it even more efficient, and I'll show you some video about that. And really from an economic standpoint, when we can use a laser therapy and decrease the intraocular pressure, or use a laser therapy to augment maybe anti-VEGF therapy and decrease the amount of injections we need for these patients, overall, basically we're going to reduce that cost for the patient. And if we can reduce the cost for the patient and also reduce the cost of the healthcare system, I think we have a win-win situation. From an expense to the practice, being a dual laser platform, you have to remember this talks about MicroPulse, but you have to also realize that this laser is also a continuous wave laser. So really you got the benefits of using it for a continuous wave laser when you're treating, say, a PRP or doing retinal tears, but it also gives you that MicroPulse treatment for treating glaucoma as well as retina. So if you have a multi-specialty practice that's looking for a laser, you have the advantage of this laser. And ultimately, keeping these patients happy, keeping them in your practice is really why they're there. They want to be in your practice, so this laser allows them to be in your practice, and ultimately that will increase your practice revenue. So I currently use the 532 laser. I have had experience with the 577 laser, as well as the original 810 diode laser. When I do a treatment, I'll do a high-density application with a very confluent manner over the retina. The nice thing about the tech cell, though, is it will give you a pattern-generated laser that gives you a targeted area that you can see and visualize, and then I can apply a very predictable and consistent laser delivery over that area of edema. It really improved my efficiency. It's made the treatment much more easier to perform. So as a surgeon or laser surgeon performing the operation, you can get the procedure done fairly quickly, which is really nice for the patient, because as a patient having a laser aimed at your eye, you want to have it over with as quickly as possible, and I think the tech cell has really helped in that. And the versatility of this laser, like we talked about before, it can be used as a continuous wave laser or a micropulse laser, and it can be used for both the anterior as well as the posterior segment. So when you look at this slide, you can see the original argon-treated eyes when we create those high, heavy burns versus like the modified ETDRS, which would be a little bit less intense burn. But either way, you're creating a burn. And really the biological effect that we're seeing is not the burn, but it's the area surrounding the burn. And that's where we're really getting the therapeutic effect. So if you think about it for a moment, if we can create the therapeutic effect but not have the burn or not have the damage, wouldn't that be better? And that's really what MicroPulse technology is doing. So if you look over on the far right of the screen, we'll see an area of a high-density, low-intensity treatment, which is creating the biological effect we're looking for, basically decreasing the edema of the retina, but not creating the thermal damage. And it's a great technology, and I'm surprised this wasn't even developed years ago. So here's an example of treating with the tech cell. This is doing a 7x7 grid with no spacing in between, using a 200 micron spot size, 200 millisecond duration, and 400 milliwatts of power. And we're using a 5% duty cycle, and it's very important to remember that. When you're treating the retina, do not use anything higher than 5% duty cycle. The 5% duty cycle is safe. We see no uptake on fluorescein angiography or autofluorescence or in the OCT after the treatment with a 5% duty cycle. But if you do increase that duty cycle, you're going to have that potential of creating a retinal burn. This is in the continuous wave mode, so this is me doing a PRP. It's very nice. I do a 3x3 grid. You can do it up to a 7x7, but in my hands, it's just a little bit sloppy. So I stick with the 3x3. It seems to work very quickly. Patients tolerate fairly well, and it's a great way of just getting the applications in, and it looks really nice afterwards. So really, I've incorporated the MicroPulse into my practice as a first-line treatment. Remember, we talked about using it for glaucoma, and so from my standpoint, I do offer it to the patients. We have the opportunity to use medications and or laser. And early on, when people were starting to use laser for the treatment of glaucoma, patients were a little skeptical. They didn't know if they wanted to have the laser done. And then all of a sudden, we started doing LASIK eye surgery, and everyone had laser surgery, and they saw better. So it was one of those things where I think people became more accustomed to the use of laser, and it became a little bit more commonplace for patients to have laser performed. I'll use it as an adjunct to my current therapy. I don't want to say anti-VEGFs are bad. They're still useful, and they're very useful, especially with MicroPulse in combination for treatment of these patients who have macular edema. I'll use it in conditions where glaucoma therapy is failing us, maybe as to save the person an eye surgery in the future. And like I said, there's many retinal applications that are available, whether you're treating diabetic macular edema, branch vein occlusions, radiation retinopathy, and even MACTEL. So I'm going to run through about 8 cases real quickly. This is early on in my treatment with the MicroPulse. This patient had avastin 1 year prior, but they did have a stroke afterwards. And as we know, with any of the anti-VEGFs, we're always concerned about myocardial infarctions and non-lethal cerebral vascular accidents. So from our standpoint, this guy said, nope, no more injections. I want to stay away from anything that could potentially cause me to have another stroke. So we did a MicroPulse treatment on this patient, and this is 4 months post-treatment. Some resolution of the edema with visual acuity improving from 20/50 to 20/30, and this is with just MicroPulse applied. This next case is a patient with chronic diabetic macular edema. This patient has had multiple continuous wave grid therapy, also steroid injections with really no improvement of their macular edema. Patient's visual acuity is 20/50, underwent MicroPulse treatment. Here we are 3 months post 1 MicroPulse treatment with visual acuity improving from 20/50 to 20/30 with nice resolution of the edema. Next case is a patient with chronic diabetic macular edema, has had 5 avastin injections. MicroPulse was carried out in December of 2011. This is prior to Texel, so I was doing a paintbrush technique, basically going across, up and down, side by side to be able to treat that area of edema. Visual acuity is 2200 pre-MicroPulse, and here we are at 20/50 post-MicroPulse. This is 13 months after MicroPulse laser, no additional anti-VEGF therapy. So this patient had multiple treatments before, didn't respond, did respond to laser. Here's another case of a chronic macular edema due to a vein occlusion. This patient had multiple continuous wave laser therapy along with Kenalog injections. Visual acuity remained at 20/60. Here they are post-MicroPulse treatment 11 months later. Visual acuity improving from 20/60 to 20/25 with nice resolution of the edema. Next case is another case of a branch vein occlusion. This patient had no prior treatment. Visual acuity is 20/50. They came into the office and we offered either MicroPulse and or anti-VEGF. The patient actually opted for the laser. And we did the MicroPulse laser. Now the interesting thing is I never see the patients back in a week, but this patient came back to my office 1 week later and said, my vision's better. And I thought, okay, this is psychosomatic. The patient just had laser done. They're thinking, yeah, their vision's going to be better after having laser done. But this is 1 week after MicroPulse. Now, you're not going to typically see these effects occur, but in this case, it just happened. This patient had no adjunctive therapy. Visual acuity is still down 20/40, but definitely resolution of quite a significant amount of that edema. Here's one with a combination of using avastin along with MicroPulse and combination therapy. This is a patient with a branch vein occlusion, markedly edemic, and visual acuity of count fingers at 6 feet. Patient had avastin injection. We can see improvement of the edema. Vision acuity actually improved from count fingers at 6 feet to 2300. However, we still see a marked area of edema that's still present. So the patient underwent MicroPulse treatment, and here we are after the first MicroPulse treatment. We can see some of the edema resolving. Visual acuity, though, stayed about the same, 2300. If you look right around the central area of the macula, you might see even a little reaction that can sometimes take place with MicroPulse, so don't be alarmed if you may see some reactive edema early on. That will clear over time. But the patient did undergo a second MicroPulse treatment, and their vision acuity still improved from 2300 to 2100 with more resolution of the edema. So here's that patient again, pre and post combination therapy with 1 Avastin and 2 MicroPulse injection or MicroPulse treatments, with vision improving from count fingers at 6 feet to 2100. This patient probably would have required at least 5 or 6 anti-VEGF treatments to get the same effect. So I thought this was a nice combination therapy to be able to use. This one happens to be my golf partner. He was a Vietnam veteran who ended up with ocular lymphoma and radiation to his orbit. Ended up with chronic macular edema and metamorphopsia. Visual acuity was 2100. And patient underwent MicroPulse treatment. Vision 17 months later improved to 2080 with resolution of the edema. Visual acuity is probably going to still remain 2080, though. If you look at his fluorescein angiogram, you'll see an enlargement of the foveolae vascular zone due to the ischemia from the radiation that he had. So, but overall, he did say his metamorphopsia was better and that he was able to see better. And the last case is that of someone with macular telangiectasia who had some metamorphopsia and chronic edema. This patient was treated, and visual acuity improved from 2040 to 2025. These are very difficult sometimes patients to treat because you're going to end up with juxtafoveal scotomas if you're using a continuous wave laser, and they responded very nicely to the MicroPulse laser. So some of the treatment pearls to take back with you for retinal applications, I will use adjunctive therapy. I think anti-VEGF therapy is here and it works, but we don't want to constantly be injecting these patients on a monthly basis to treat their retinal edema. We do know, and I'm sure Dr. Reichel will also show some information about the DRCR-net and how we can use a combination of both anti-VEGFs and laser to help these patients better. And also, you want to complete a high-density, low-intensity treatment over the edema. And I think early treatment of these patients is better. If you can treat these patients when they have minimal edema, they definitely respond to MicroPulse better. Or if you can decrease the amount of edema they have with the anti-VEGF therapy, they'll respond to MicroPulse better, and it'll be longer lasting. And don't forget, you want to make sure you use the 5% duty cycle to treat through the fovea. And also, sometimes with these patients, post-MicroPulse, watchful waiting is important because some of these people will get a delayed effect over time. So if you watch these people long enough, they'll continue to improve. Thank you.
Thank you, David. All right, well, we'll get Elias up here to speak from a retinal perspective. His title is Diabetic Macular Edema, Role of Laser and MicroPulse Strategies in the Anti-VEGF Era.
Thank you, Ike. Thank you, David. In this day and age of anti-VEGF agents, it's really important to still consider the use of laser photocoagulation for treating patients with diabetic macular edema and other retinal vascular occlusive disorders. So we really can't ignore lasers, and they still play a very useful role. And I'll go through the history of micropulsing and then talk a little bit about why laser is still important, even with anti-VEGFs. So where did this all start? Really, when you consider laser, we were looking at coagulation necrosis of the retina, and you can see here that on the left-hand panel, there's a full thickness burn through the retina when we've used threshold laser or even subthreshold continuous wave laser. On the right-hand panel, you can see that there's minimal destruction, minimal damage, and you can actually see where the laser burns are. You can see that there's a little shrinkage of the thickness of the retina, but in general, the morphology of the retina appears to be normal. And that treatment was done with micropulsing on the right-hand side. So the next few panels are going to really look at the use of the infrared laser, the 810 nanometer laser, for doing micropulsing. So this is a little bit dated, but it's very important information, and this was done by Vucicevic in 2010. It was published in Retina. And what they did was they compared modified ETDRS laser photocoagulation with conventional laser compared to 810 nanometer micropulsing. And you can see here on the left-hand side, the modified ETDRS, that macular edema gets better. Laser works, conventional laser works, but look at the retinal sensitivities. Retinal sensitivities, you're seeing more yellow in the upper right-hand panel for the modified ETDRS. So sensitivity does change. If you look at micropulsing, you have resolution of macular edema. However, you have more green, so retinal sensitivity is preserved. So that's a significant finding, and they looked at a series of 60 eyes and showed that you can show improvement in retinal sensitivity with using micropulsing compared to conventional photocoagulation. So some of the other protocols that people have looked at, these are basically large case series. We talked about the Retina 2010. Levinsky looked at modified ETDRS versus micropulsing, and they saw improvement in visual acuity relative to modified ETDRS, as well as central macular thickness reduction. The follow-up in that study was a year. Geoff Latrell has done a lot of work in this area. He's really to be credited to being dogged at looking at micropulsing, and he has 10 years follow-up in some patients, and it's really effective, as David showed, in many types of retinal vascular diseases, including diabetic macular edema and retinal venous obstruction, for reducing macular edema. So Levinsky's paper compared 3 approaches to using laser photocoagulation. One approach was the modified ETDRS. Another was micropulsing, either high density or low density micropulsing. And the cartoon that was shown earlier, which I will show again, compares low density versus high density micropulsing. And you can see here that with micropulsing that's done at a high density, you had the best improvement in visual acuity. You had almost a 50% gain in 3 letters in patients in this study, compared to low density micropulsing, where it was only about 5%, and modified ETDRS had improvement in between those two. So it really does suggest that high-density micropulsing is a very valid approach. It also shows that modified ETDRS is not that bad. So Geoff Latrell's work, this is from his paper. You can see that starting from the bottom of the slide, a patient was treated with micropulsing, and you can see resolution of macular edema. What's interesting about this work is that he looked at the duty cycle, and if you altered the duty cycle, it does affect your ability to have a successful result, meaning that 5% duty cycle, remember that, 5% is good. It's safe for the fovea. But if you go to a higher duty cycle, you may have laser-induced retinal damage. And if you go to a 10 or 15% duty cycle, you're seeing about 1 out of 10 patients developing some kind of retinal damage. So it's important to remember 5% duty cycle. And this is long-term follow-up. These patients were followed for up to 10 years. So this is the cartoon or the schematic showing the different varieties of micropulse application. And it's important to remember that with continuous wave laser photocoagulation, if you're doing a grid type of pattern, you're only treating 10% of the retina at any given point. So if you're using a grid pattern throughout most of the macula, most of the time you're only treating 10% of the retinal pigment epithelium. The thing about micropulsing and really subthreshold laser is that you really have to treat the entire retinal pigment epithelium to see a significant effect. And the more of the retinal pigment epithelium you treat, probably the better pump function you're going to induce, and some of these cytokines that you're trying to either inhibit or activate will be at a relatively higher level than if you do a sparing grid photocoagulation. So that's really the box that's circled here. If you look at that, low intensity, high density treats more of the retinal pigment epithelium in a way that positively affects macular edema due to retinal vascular obstructive disease and diabetic macular edema. So now we're going to transition into comparing 810 nanometer infrared micropulsing to yellow 577 nanometer micropulsing. And this work was very carefully done. These patients received very similar treatment protocols, but remember the power is different with infrared. You're going to have to go to a higher power, and the average power that was used was 750 milliwatts. With yellow, you use less power, and this is true whenever you use the infrared laser. You're going to have to crank it up a little bit higher to see some type of threshold or subthreshold burn. And so in this study, they actually looked at 250 milliwatts for 577 nanometers. And that's an important number to remember. That's really the baseline where you're going to start with micropulsing using 577. You can go higher. We are currently exploring higher treatment powers, but at the very start, 250 milliwatts is the appropriate. And again, 5% duty cycle is critical for success. So in this study, they looked at 577 versus 810 micropulsing, and there were really no absolute scotomas. There were no changes on fundus autofluorescence, and in microperimetry, there were no changes in comparison between the two wavelengths. If you look at the outcomes of these patients, they were similar, meaning that if you look at central retinal thickness, CRT, you can see that there's a decrease of about 30 to 40 microns over 6 months follow-up after being treated with the MicroPulse laser. In addition, careful examination with reading center revealed that there were minimal laser scars, and there were really no changes on fundus autofluorescence or fluorescein angiography. So this is really the heart of what I want to talk about, and this is the RIDE and RISE data using Lucentis for the treatment of diabetic macular edema, and it's being compared to sham treatment. And in the sham treatment arm, they were able to receive laser, but only 72% of patients in the sham arm actually did receive laser, which means 1/4 of the eyes received no treatment at all. But if you look over 3 years, patients still tended to benefit with a few laser treatments. The average number of laser treatments in the sham arm was 3 over 3 years, and they gained almost 5 letters of vision over 3 years, compared to 12 letters of vision with the Lucentis-treated eyes. So what does this tell us? It tells us that laser does something and laser works. And you don't need to do many lasers over a 3-year period to show some kind of benefit. However, there is more of a benefit with anti-VEGF treatment over the 3-year period. Well, DRCRnet also looked at a variety of treatment protocols. And in Protocol 1, which is a really important study, you can see that they compared triamcinolone with prompt laser, and prompt laser means laser within 1 week of doing the injection. They compared sham with prompt laser, again, within a week of the injection. They compared ranibizumab with prompt laser, and also Lucentis or ranibizumab with deferred laser. And deferred laser means laser 6 months after the initial injection. So which patients had the best results? Well, if you look at the blue line, those are the patients who received Lucentis with deferred laser. And so what's really interesting here is that you have a significant benefit even after you do laser 6 months after the anti-VEGF injection. Now remember, this was with conventional laser. This is not using micropulsing. But it tells me that there's still a role for laser in treating patients with diabetic macular edema. And in addition, if you look at the purple line, it mirrors what was found in the RIDE and RISE Lucentis studies. Patients received, and actually in this study, they only received up to 2 laser treatments, but yet there's about a 4-letter improvement in vision over a 2-year period. Again, there is a role for laser, and there's not only a role for laser alone, but in combination with anti-VEGFs. And I think that's probably the most important thing that has come out of DRCRnet, is that combination treatment, whether it's combination with corticosteroids, anti-VEGFs, or laser, they are very important in treating patients with diabetic macular edema. So this was one of my first cases. This patient was treated 20/50 vision, has modest macular edema. You can see that there's red in the center of the topographic image. There's thickening of the retina. This patient received treatment through the fovea. You can see that this is involving the fovea. And I have to say that this patient had bilateral disease. So he got treated the same day, one of my first patients, both eyes, and follow-up 2 months later, so relatively short follow-up. You can see that there's less red, that white spot has disappeared. His vision improved to 20/40. The horizontal line scan looks significantly better. This is the left eye, and you can see that there's more thickening here. This is 500 microns of thickening. This patient received no anti-VEGF injections, by the way. This was monotherapy, 20/60 vision, returned to, again, 2 months later. That white has changed to red, meaning that there's less thickening. And you can see the horizontal line scan looks better, and this is only 2 months later. So I was really impressed with this result. Bilateral disease, treated the same day, patient's vision improved, OCT shows marked response. So in conclusion, MicroPulse laser therapy is less tissue destructive, and we now have case series and clinical studies showing the relative preservation of function and reduction in diabetic macular edema. Anti-VEGF combined with deferred conventional laser shows greatest treatment effect in DRCR-net. However, I think that those results are going to be mirrored with micropulsing, and I'm hoping that we do a clinical trial to show that micropulsing being safer but equally efficacious to conventional laser, particularly when used with anti-VEGF agents. Thank you.
Thank you, Elias. That was a powerhouse talk, and we have a few minutes left for our discussion. So I'm going to have to leave a bit earlier, but I wanted to start off with some glaucoma questions for Elias. No, I'm kidding. I'll take that. Don't worry. Is MLT really different than SLT? Well, we think about the mechanisms of action. I think they're very similar in terms of their energy causing cytokine release and macrophage activation. Where there may be differences is what we're seeing in terms of some of the AC cellular response and some of the inflammation and potential pigment issues. That may be where there may be differences on that. No comparative study done yet on SLT versus MLT. ALT, spot size 50 microns and MLT 300 microns. Someone asked about doing a PI. You certainly could, like you would with an argon laser. I typically use a YAG, but you could use this platform to do initial thinning of the iris, chipping away at it for a thick brown iris as well. You typically see a result often literally in a few hours, but usually you wait 1 to 3 months before getting a full response. I agree with David that even if you don't get a response at 1 month, we sometimes see a few percentage of patients that will show a response at 3 months. And that's typically what we do. For normal pressure glaucoma, looking at the collaborative normal pressure glaucoma study where patients were treated with laser trabeculoplasty or pilocarpine or Diamox, certainly a number of patients did quite well with laser trabeculoplasty. I think it's worth considering. But if we're trying to get pressures down below 12, it makes it difficult to do without, of course, using a filtering procedure like trabeculectomy. So I think that's something to keep in mind. Pigmentary glaucoma, we don't have a problem, as I said. We use 360. Steroid response, for sure. I think it can definitely be used, and we do this as a temporizing measure. Neovascular glaucoma, however, I would not suggest using laser trabeculoplasty with, as well as angle recession. I think the mechanism is unlikely to be effective on that. So those are my quick answers as far as that. I know there's a question about repeatability. How many patients require retreatment? Maybe I'll let Dave handle that one. The question was, what percentage of patients require retreatment using MLT trabeculoplasty? And then I'll let David and Elias handle the retina stuff. So thank you.
Okay, thanks.
Thank you. Well done. Thank you very much.
Well, with repeatability, early on when I was treating with 300 milliwatts and 700 milliwatts, some of those patients didn't get the pressure lowering effect that I was looking for, so then I would use 1,000 milliwatts in those patients and found that I could get additional effects. So from a repeatability standpoint, I'm kind of limited in how many patients that I've actually repeated with 1,000 milliwatts alone. Probably I have maybe a handful or less of those patients that were treated at 1,000 milliwatts that I've had to repeat treatment. When I did apply treatment again, though, they did respond. So from a standpoint of repeatability, it's a very limited number, but those patients did have an additional effect from that. So we'll kind of move on to some retina questions. The first question was, how do you titrate the power if you don't really see an endpoint? That's a good question. And early on with MicroPulse technology, what we used to do is you'd start off with the continuous wave mode, and you would start off with, say, 100 micron spot size, 100 milliwatts, and 100 milliseconds. And what we would do is then we would titrate up the power until we saw a little whitening of the retina. Now remember, this is in continuous wave mode. So once we saw that we were getting to a threshold burn, or very light subthreshold burn, at that point what we would do is switch it over to the MicroPulse. We would keep it at 100 micron spot size. We would double the power setting at what we saw get the burn. So if you're at 150 milliwatts, you would then double it to 300 milliwatts. And we would also double the duty cycles, or not the duty cycle, but the time. So we would go to 200 milliseconds. And that seemed to work pretty well for those patients that we were treating prior to Texcel. As we went on and eventually got the Texcel laser, I have a tendency to start off with a 5% duty cycle. I'll use a 200 micron spot size, 200 milliseconds, and I'll use 400 milliwatts of power. I've used that before. I've treated patients over the fovea, and there's always a big question is, can you treat over the fovea? And with the 5% duty cycle, I've seen no ill effects in 2.5 years of doing this. If you brought them back and did an autofluorescence on them or fluorescein angiography on them or an OCT, you're going to see no harmful effects as long as you're using the lower duty cycle. Next question. Can you treat inside the foveal vascular zone?
You can. I mean, the first case, the case I showed was right in the FAZ and, no untoward effect. I think if you're starting out, I'd start out at lower, dosimetry, 250 milliwatts, build some confidence. I've visited a couple of practitioners who are using this, and everyone seems very confident that starting at 250 is great, and actually people are moving up to, as David said, the 400 milliwatt range now.
And can you comment on microperimetry results?
Well, the microperimetry results are interesting. I think that it's hard to look at microperimetry results very critically in diabetic eyes because they're reduced anyway. And if you actually look at this, one of the studies that's in the handout, actually retinal sensitivity dropped after treatment 6 months later. So, the question is, regardless of what you were doing. So there is a slight decrease. Whether it's statistically significant, we don't know because of the confidence intervals. So I wouldn't get too worked up about that because you're dealing with a complex disease in older individuals. Sensitivity decreases. In general, the sensitivity was in the same range as what it was at initiation of treatment.
The next question was, can you use it for treatment of central serous retinopathy? And the answer is yes. It has been used and applied for central serous retinopathy, and you do see the beneficial effects in CSR. The question again is, what's the spot size for diabetic macular edema? You can use a 100 micron spot size. I have a tendency with the Texcel to use a 200 micron spot size. It just makes the treatment go a little faster. It's a little bit quicker, and you cover more ground with the 200 micron spot size versus the 100. But there is no harm in using a 100 micron spot size.
No, I agree. Yeah, I use 200, but you could use 100.
And then the question is, if you have a laser and you're going to be using it for diabetic macular edema and also MLTs, what wavelength would you choose, yellow or green? I think, from a comprehensive ophthalmologist, we've been so familiar with using green wavelength lasers that we've been using that for years. I felt very comfortable using the green wavelength laser. I've had nice results with it. I did use the yellow for some time when we were trying out the new Texcel. I had to get my Texcel installed on my laser. I got a chance to use the 577. I saw really nice results with the 577. I think if you're a retina person, you'd probably opt for the 577 just from...
Yeah, over the years, I've become agnostic as to wavelength. I don't really think it matters. I think you could do equivalent, and actually some of the results I showed, infrared seems to be equivalent to green, which is equivalent to yellow. I don't really think it makes that much of a difference, so long as you have the right theory with micropulsing, meaning that you're getting the Arrhenius integral right. And so I think titration is easier with yellow or green. I think infrared is a little bit more difficult. But that being said, I think yellow and green are pretty equivalent.
Yeah, the other thing, too, with the yellow, though, for doing PRPs, we do what we call mini pulse. We set it at 20 milliseconds, and you can do a very fast PRP, which almost becomes painless for the patient. So the one thing that is nice about the 577 is you can treat at lesser powers and still get a nice uptake in the retina versus the 532. And the question is, do we have, it does say we have MicroPulse protocols at the booth, so, and it's not a question, it's a statement. So if you're looking for any MicroPulse protocols, you can find that at the Iridex booth. And the Iridex booth number is?
804? I think it's 804, yeah.
Okay, 804. Well, thank you.